At some point last night, your airway collapsed, not dramatically, not with pain, just a brief obstruction that cut off your oxygen supply dozens of times while you were completely unconscious. You have no memory of it. You never do. Your heart registered every single one. The word most people have been given for what happens in their bedroom at night is snoring. It is treated as a noise problem, something embarrassing to manage with nasal strips or a different sleeping position, something that bothers the person sharing the room more than the person producing the sound. For a significant proportion of adults over 60, what is being called snoring is not a noise. It is the sound of a partial airway obstruction that has been quietly damaging the cardiovascular system, the brain, and the metabolic system for years while its owner sleeps peacefully through every episode with no awareness that anything is wrong. Subscribe before we go into the mechanisms. You know the specific texture of the morning after a bad night of undetected apnea events, even if you have never had a name for it. It is not the tiredness of too few hours. It is a heavier thing, a thickness behind the eyes that is already present before you open them. A dry mouth and a headache sitting at the temples that coffee addresses for 30 minutes before it returns. A stiffness in the neck and jaw that you have come to accept as simply how mornings feel. You sit on the edge of the bed and the word that surfaces is exhausted. But you went to bed at a reasonable hour and your tracker says you slept 7 hours. And neither of those facts explains why you feel the way you feel. You carry last night's damage into the day with no information about where it came from. And by mid-morning, you are already looking forward to the sleep that will not actually repair anything either. Here is the structural problem with how this condition gets detected. Obstructive sleep apnea is only diagnosable through a sleep study that records airway events, oxygen saturation, and heart rate across the night. It does not appear on any blood panel. It produces no finding at a standard physical examination conducted during waking hours. The only pathway into clinical awareness is a patient reporting relevant symptoms with enough specificity and persistence for a referral to follow. Most patients report them as tiredness. Tiredness generates a wide differential and rarely a sleep study. Most patients do not report them at all because after 60, waking exhausted and sleeping poorly have been normalized to the point where they are simply absorbed into the background of aging. Research published in the American Journal of Respiratory and Critical Care Medicine estimated that over 80% of people with moderate to severe obstructive sleep apnea remain undiagnosed, and the majority of those undiagnosed people sit in the age group carrying the highest cardiovascular risk from the condition. Before the mechanisms, a clear line. If you regularly wake gasping, choking, or with a sensation of suffocation, those are not stress responses and not benign waking patterns. They require clinical evaluation, not a home protocol. For everyone else, the 3 mechanisms below explain what is running overnight, and the 2-part protocol that follows addresses both assessment and the changes available tonight without any equipment. Here is the fact that transforms how sleep apnea should be understood. Each apnea event, each moment of airway closure and oxygen interruption is detected by your body as an emergency. The sympathetic nervous system activates. Adrenaline and cortisol release. Blood pressure spikes, heart rate surges. The arousal is brief and partial, not enough to wake you fully, just enough to reopen the airway so that breathing resumes and the episode appears to be over. Then the cycle begins again. Think of it as a fire alarm that triggers, silences, and triggers again every 2 to 4 minutes throughout the night. Each activation is brief. The cumulative effect of hundreds of activations is not. For a person with moderate sleep apnea, this cycle runs 15 to 30 times per hour across the entire night. For severe apnea, over 30 times per hour. Research published in the Journal of the American College of Cardiology confirmed that this repeated overnight sympathetic activation is directly associated with structural cardiac changes, specifically thickening of the left ventricular wall, which is the same adaptive change that appears in people with chronic hypertension. The heart is not responding to a problem with your sleep. It is responding to hundreds of overnight emergencies and rebuilding its architecture around them. The second mechanism runs at the cellular level during each apnea event. When the airway closes, blood oxygen saturation drops. In healthy sleep, it sits between 95 and 100%. In moderate sleep apnea, it falls below 90 during events, and in severe cases, repeatedly below 80% across the night. The heart muscle itself is consuming oxygen continuously, including during sleep. And during the same hours, it is supposed to be conducting its primary repair and recovery cycle. Each episode of oxygen desaturation places cardiac muscle under direct oxygen stress during the window when it was supposed to be recovering from yesterday's load. Over years, repeated oxygen debt during the heart's own repair window produces measurable functional changes. Research published in Circulation documents that adults with untreated severe sleep apnea have significantly elevated rates of atrial fibrillation and nocturnal cardiac arrhythmia compared to age-matched controls, with the relationship strongest in adults over 60, where cardiac reserve has already reduced from baseline. The heart that should be repairing itself overnight is instead managing an oxygen debt that repeats every few minutes until the alarm goes off. The third mechanism is the one that makes sleep apnea a systemic condition rather than purely a cardiovascular one, and it is the one that surprises people most. Each cycle of oxygen drop and recovery generates oxidative stress throughout the body. Free radicals produced during the desaturation phase damage cell membranes in tissue far beyond the heart and the airway. The body responds to this repeated oxidative stress by activating inflammatory pathways. Specifically, interleukin-6 and C-reactive protein, the same inflammatory markers elevated in cardiovascular disease, type 2 diabetes, and accelerated cognitive decline, are measurably and consistently elevated in people with untreated sleep apnea. Research published in Circulation established that CRP levels in adults with moderate to severe OSA are significantly higher than in age-matched controls, and that the elevation is proportional to the severity of the apnea, not to other lifestyle factors. The practical implication is the one most people find unexpected. Treating sleep apnea does not only reduce the direct cardiovascular damage from oxygen desaturation and sympathetic activation. It lowers the whole body inflammatory state that is amplifying every other chronic condition the person is already managing. For someone dealing with elevated blood pressure, blood sugar instability, or early cognitive changes, untreated sleep apnea is not an additional problem sitting alongside those conditions. It is the condition actively making each of them harder to manage and harder to treat. 2 parts. The first tells you right now whether you are statistically likely to have undiagnosed sleep apnea. The second reduces its severity regardless of whether a formal diagnosis follows. Part 1 is the Stop Bang Self-Audit, a validated clinical screening tool used in sleep medicine internationally. Score 1 point for each yes. Do you snore loudly enough to be heard through a closed door? Have you been observed stopping breathing during sleep? Do you feel tired, fatigued, or sleepy during the day most mornings, regardless of hours slept? Do you have or are you being treated for high blood pressure? Are you over 50? Is your neck circumference greater than 40 centimeters, approximately 16 inches? Are you male? A score of 3 or above indicates intermediate risk of clinically significant sleep apnea. A score of 5 or above indicates high risk. This score is not a diagnosis. It is the structured clinical language for the conversation with your doctor about whether a sleep study is the appropriate next step, and it is significantly more productive than arriving and saying you are tired. Part 2 is available tonight. Sleep on your side rather than your back. The supine position allows the tongue and soft palate to fall backward passively, narrowing the airway before a single breath is taken. A firm pillow wedged lengthwise behind your back maintains the lateral position through position changes during the night. Elevate the head of your bed by 4 to 6 inches using risers under the bedposts rather than stacking pillows under your head, which bends the neck forward and worsens the obstruction it is meant to relieve. Stop eating at least 3 hours before sleep. A full stomach elevates the diaphragm and reduces the space available for full lung expansion, increasing the effort required to maintain an open airway under the relaxed muscle tone of sleep. Research published in the Journal of Clinical Sleep Medicine documented that positional changes alone reduce apnea event frequency by a clinically meaningful amount in a significant proportion of patients with positional obstructive sleep apnea. These changes cost nothing and take effect from the first night. 1. Run the Stop Bang audit right now and write your score. 3 or above is the threshold for raising this specifically with your doctor, not as tiredness, but as a scored screening result. 2. Change your sleep position to your side tonight. Place a firm pillow behind your back before you get into bed so the change is already set up when you lie down. 3. If you share a bedroom, ask the person in it tonight whether they have ever noticed pauses in your breathing. Ask specifically for a duration if they say yes. That information is worth more than any symptom you could describe from memory. 4. If your Stop Bang score is 5 or above, book a doctor's appointment this week and bring the number. A scored screening tool moves the conversation to a different place than a complaint about sleep quality. 5. Set your last food tonight at least 3 hours before you plan to sleep. One night of that change costs nothing and begins building the evidence to yourself that the protocol is practical. I want your Stop Bang score in the comments before you close this. Write the number. Then write the one symptom from the audit that you recognized most clearly in yourself, the one you have been describing as something else, calling it age, stress, too much coffee, not enough water, anything except what it might actually be.